Day, everybody. Thank you for joining us today. This is going to be our last session for this Congress. This is going to be our last plenary session. I'm delighted and honored to invite to give the presentation today Dr. Aliya Khan. Dr. Aliya Khan is a professor of clinical medicine at McMaster University. She's a director of the Calcium Disorders Clinic and the fellowship in metabolic bone disease at McMaster University. She has numerous publications, numerous book chapters about osteoporosis and parathyroid disease. She has also received multiple awards regarding her work, including International Osteoporosis Foundation Award for Publishing Excellence, and recognized by the Osteoporosis Canada for outstanding contribution to research and education. So welcome, Dr. Aliya Khan, for your presentation.
Hello, everybody. It is my pleasure to speak to you today on the new global guidelines and the diagnosis and management of primary hyperparathyroidism. And I really would like to thank the Arab Thyroid Association for this kind invitation. And I'm going to present an overview of the new recommendations. So I will just advance my slides. So I have received research support from a number of the industry partners, and these are my disclosures. And we will be talking about how do we make the diagnosis of primary hyperparathyroidism, how do we evaluate for the end organ manifestations, and if we choose not to proceed with parathyroid surgery, are there medical treatments available and what is the evidence to support their use? And we'll also see a little bit about parathyroid disease in pregnancy. So I wanted to begin with a case of a patient that we saw recently at McMaster University. And this was a 30-year-old woman. She was 33 weeks pregnant. And the reason that she came to the hospital is because she was having leg pains for several months. Several months of leg pain. And on further questioning, she said, yes, she was feeling thirsty and she had polyuria that dated back for about 1 year. But the reason she came to the hospital was because of the leg pains. So the polyuria and the polydipsia was not really a reason for her to come to medical attention. And the reason why I'm emphasizing that is because young people can tolerate severe hypercalcemia very well. And the increased fluid intake, so they're well hydrated. And look, her corrected calcium was 4.02 millimoles per liter. And that is 16.1 milligrams per deciliter. So she had severe hypercalcemia. And her PTH was 40 times normal at 147 picomoles per liter. Her vitamin D levels were low, 14 nanograms per ml or 36 nanomoles per liter, and the alkaline phosphatase levels were high. So she had increases in bone remodeling because of this very high PTH. And she also had renal impairment. You know, for a 30-year-old woman, a GFR of 60 is low. Her serum magnesium was just in the normal reference range, and the calcium to creatinine clearance ratio was 0.051. And so her x-rays were done, and this is what was seen. She had a large area of lucency involving the cortical and the cancellous bone, and this was 6 by 3 centimeters in diameter. And it had some aggressive features. It was involving the cortical bone, and usually brown tumors do not involve the cortical bone. But this one, we were concerned. You know, we thought that because her calcium was so high and her PTH was very high, we thought she might have parathyroid cancer with metastatic disease. But the possibility still remained that this could be a brown tumor, which is an osteoclastoma, and the very high levels of PTH can cause major bone demineralization and cause a lytic lesion. So we do have new guidelines for hyperparathyroidism, and I will be presenting these to you. And this was the result of a major international workshop meeting, which has been held over the past 2.5 years. We had approximately 100 representatives from around the world representing societies, both endocrine societies and endocrine surgery societies, on our task forces, and we developed 2 guidelines. One was this international workshop guideline on primary hyperparathyroidism, and we also developed a guideline on hypoparathyroidism. So I wanted to begin by saying that the main regulator of PTH is serum calcium. And we know that when calcium levels go down, this will be sensed by the calcium sensing receptor, which is sitting on the surface of the chief cells in the parathyroid gland. And when calcium levels go down, PTH goes up. And when PTH goes up, it will immediately increase calcium reabsorption through the kidney. And the minute-to-minute regulation of serum calcium is really through renal calcium reabsorption. So every day we filter 10 grams of calcium through the kidney, and we reabsorb 9.8 grams. Now, when calcium levels are low, we enhance calcium reabsorption through the kidney, and that is by the effects of PTH. And this happens within minutes. And if that hypocalcemic insult persists, then we will see bone resorption. So PTH will bind to PTH receptors on osteoblasts and increase the release of rank ligand. And rank ligand will increase the formation and the function and survival of osteoclasts, and that will cause bone resorption. Now, when there's bone resorption, that will be associated with release of calcium and phosphate into the bloodstream. And that will help to bring that calcium back into the normal reference range. So when calcium goes down, we see rises in PTH, increased renal calcium reabsorption, cause bone resorption with an increase in calcium and phosphate release from the skeleton. And we also increase the hydroxylation of vitamin D so that it forms 1,25-dihydroxyvitamin D, which further increases the absorption of calcium and phosphate from the bowel and will also cause bone resorption. And through these mechanisms, we will bring that serum calcium back up into the normal reference range. Now, people who have parathyroid disease could have this because of an adenoma. And a solitary adenoma is the cause of primary hyperparathyroidism in 85% of patients. The remaining 15% usually have this on the basis of hyperplasia. And very few, less than 1%, will have parathyroid cancer. Now, in people who have parathyroid adenomas, there is a decrease in the expression of the calcium sensing receptors. So there are fewer receptors and there's more parathyroid tissue. And so calcium levels are rising, but they're not turning off PTH. Because when calcium goes up, PTH should go down. But that's not happening. And the reason why it's not happening is because we don't have enough calcium sensing receptors in the parathyroid tissue, and we have too much parathyroid tissue in the adenoma or in the hyperplastic parathyroid tissue. So how do we make the diagnosis of primary hyperparathyroidism? Well, we need to have a high serum calcium. If you don't have high serum calcium, you don't have a diagnosis of primary hyperparathyroidism. And remember, calcium binds to albumin. Half of the calcium is bound to albumin. So we have to correct for the calcium binding to albumin. So the corrected calcium is the measured calcium plus 40 minus the albumin times 0.02. So if the albumin is higher than 40, we will be subtracting. We will be correcting downwards for the calcium. And if the albumin is low, we will be correcting upwards. So we have to have a high serum calcium, and we have to have a high or an inappropriately upper normal PTH. Because when calcium goes up, PTH should be turned off. But if it isn't turned off, then that is a sign that there's a problem with the parathyroid gland and our patient has primary hyperparathyroidism. But we have to make sure that there are no other conditions present which can mimic this appearance. One of those drugs is hydrochlorothiazide. Hydrochlorothiazide increases calcium reabsorption through the kidney. And if our patient is taking hydrochlorothiazide, we have to make sure that they stop this medication and repeat the lab profile in 6 to 12 weeks. In some situations, like our patient, we don't have that time luxury. You know, she's severely hypercalcemic. We have to make the diagnosis quickly and we have to take action. But otherwise, we would stop the hydrochlorothiazide and repeat the lab profile in 3 months. If it's severe hypercalcemia, you could repeat it as early as 6 weeks. If the patient is on lithium, what lithium does is it increases the set point for suppression of PTH. It's hard to stop lithium. So sometimes we just work around it. We also measure urine calcium and urine creatinine, and we calculate the calcium to creatinine clearance ratio. And we take the urine calcium times the plasma creatinine and divide it by the urine creatinine times the plasma calcium. Remember, the plasma calcium has to be corrected for albumin. And the urine creatinine and the plasma creatinine, everything has to be in millimoles. So you have to convert everything to millimoles. Now, if our patient has an inactivating mutation of the calcium sensing receptor gene, then the calcium sensing receptor sitting on the surface of the chief cells is less sensitive. So calcium is binding to the receptor, but it's not turning off PTH. And that is a condition called familial hypocalciuric hypercalcemia. Now, why do patients have hypocalciuria if they have this inactivating mutation of the calcium sensing receptor gene? And the reason why that happens is because these calcium sensing receptors are in the kidneys as well. And they're in other tissues as well. But in the kidney, when calcium binds to the calcium sensing receptor, it increases urine calcium excretion. But if someone has an inactivating mutation of the calcium sensing receptor gene, then the calcium is binding to the calcium sensing receptor in the kidney, but urine calcium is not increasing. So there's a relative hypocalciuria, and the calcium to creatinine clearance ratio is less than 0.01. Now, remember, this is not 100% sensitive or specific. And we have to remember that between 0.01 and 0.02, because in primary hyperparathyroidism, usually this ratio is more than 0.02, and in FHH, it is usually less than 0.01, but 40% of patients with primary hyperparathyroidism and 40% of patients with familial hypocalciuria are between these two numbers. So if your patient is in the gray zone, you have to decide, is this more likely to be primary hyperparathyroidism or more likely to be FHH? And to make it even more interesting, 10% of patients with FHH have a calcium to creatinine clearance ratio, which is more than 0.02, where you would expect it to be if our patient had primary hyperparathyroidism. And up to 20% of patients with primary hyperparathyroidism can have a calcium to creatinine clearance ratio of less than 0.01. So how can we decide? Does our patient have FHH or does our patient have primary hyperparathyroidism? Well, we can look at family history. And if there's a positive family history, and if there's lifelong hypercalcemia, then it's more likely to be FHH, although it could still be familial isolated hyperparathyroidism with a positive family history. And in younger people, we are more likely to have FHH, and we might want to do DNA analysis of the calcium sensing receptor gene. We can have an inactivating mutation in the calcium sensing receptor gene, that is FHH1. You can have an inactivating mutation of the GNA11 gene, which is FHH2, and an inactivating mutation of the AP2S1 gene is FHH3. But we need to do DNA analysis. Other reasons why the calcium to creatinine clearance ratio can be low are low intake of calcium. So there's a greater absorption of calcium through the kidney, low levels of vitamin D, and impaired renal function. So these are some of the reasons why our patient could have a low calcium to creatinine clearance ratio, and we would evaluate our patients to ensure that we have the right diagnosis. And if you're concerned, then always do the DNA analysis, because then you'll have a molecular diagnosis. If patients do have primary hyperparathyroidism, they can have brown tumors, and this is what a classical brown tumor looks like. And they can also have salt and pepper skull with diffuse demineralization of the skull and increased lucency of the outer and inner table with cortical porosity. Now, how should patients be evaluated? Well, clearly we have to measure calcium and correct it for albumin. We have to check the ionized calcium. We check phosphorus. Usually phosphorus is either normal or low, because what high levels of PTH do in the first phase is have a phosphaturic effect. And this is such a beautifully designed system that in the first phase, when PTH is high, we have phosphate excretion through the kidney, because the second phase is bone resorption, and there will be release of calcium and phosphate into circulation. And so we have phosphate goes down a little bit, and because this will accommodate for the release of phosphate from the skeleton. We want to measure PTH, and before we confirm the diagnosis, we have to have at least 2 times we have to check the calcium and PTH at least on 2 occasions, confirming an elevated calcium with an inappropriately upper normal or clearly elevated PTH value. And so you want to do it on a number of occasions and look at the calcium to creatinine clearance ratio before we confirm the diagnosis. We also want to look at bone density, because we know that there can be demineralization of the skeleton, and we look at the lumbar spine, hip, and radial site. We recommend imaging of the spine. If you have vertebral fracture assessment, that would be recommended, or you can do spine x-rays. We also recommend the trabecular bone score, because this can evaluate the microarchitecture and give us an assessment of the quality of the bone. Now, what is the long-term effect of excess primary hyperparathyroidism? And the largest and the longest randomized controlled trial comparing surgery with observation evaluated 191 patients with asymptomatic primary hyperparathyroidism. This was a 10-year prospective study, and patients had mild hypercalcemia. If they had severe hypercalcemia, they were not included. And people who had kidney stones or kidney disease were not included as well. And they were followed. So they had baseline x-rays. They had x-rays done at 2, 5, and 10 years. And this is what was seen. So in mild primary hyperparathyroidism, there was no difference in cardiovascular or cerebrovascular morbidity, and mortality was low, and it did not differ between the 2 groups. There was also no difference in peripheral or vertebral fractures, whether you had parathyroidectomy or you didn't. Now, 1/4 of the patients withdrew, so that reduced the effects of the ability of our ability to draw conclusions from this study, because the power of the study was decreased. But what we can say is that medical observation appears to be safe in mild primary hyperparathyroidism. So if you have an older patient who doesn't want to go for surgery and hasn't had any fractures and hasn't had kidney stones and has well-maintained renal function with only mild hypercalcemia, you could offer them medical management. And also in patients who have multiple endocrine neoplasia, we know that the condition can recur. and about 50% will have recurrence within 10 years. So in these individuals, instead of repeatedly sending them for surgery, because that can make them hypoparathyroid, we could follow them with medical management. So we do recommend that we evaluate the skeletal status, the renal status, and we would make recommendations on intervention on that basis. Kidney stones are more likely in patients with primary hyperparathyroidism. Previously, in 3 or 4 decades earlier, they were present in 80% of patients with primary hyperparathyroidism, but now we're seeing them only in 7 to 20% of patients. It's still much higher than patients in the normal population. So in people who have normal parathyroid function, the incidence of kidney stones is 1.6%. But patients with primary hyperparathyroidism, the incidence is definitely higher at 7 to 20%. And they are more common in younger males with primary hyperparathyroidism. The urine calcium is higher in stone formers. And after parathyroidectomy, the risk of stone recurrence goes down, but it does not normalize. And we do recommend that if someone has primary hyperparathyroidism, especially if they've had a kidney stone, that we look at the other parameters that can be associated with kidney stones, such as urine calcium, oxalate, citric acid, cysteine, and pH. And also, if our patients have significant renal impairment, this is associated with more severe disease. And this would be another reason to be aggressive and recommend surgery in these patients. What we have seen, we do have some data confirming that after parathyroidectomy, there is a protection from declines in renal function. And parathyroidectomy prevents this decline in renal function. So we have data showing us that parathyroidectomy will preserve bone density. In fact, we see increases in bone density by 10% over the next 10 years. We see protection in terms of renal function, and we see a reduction in kidney stones, and we see a cure. So the hypercalcemia will be resolved. So parathyroidectomy is always a good idea, but in certain circumstances, it is particularly important for us to recommend parathyroidectomy. We need more information regarding non-classical manifestations of primary hyperparathyroidism, such as impact on cognition and on cardiovascular and on the GI manifestations. There are other phenotypes of primary hyperparathyroidism. A patient can have symptomatic disease if they have skeletal and renal complications, and they can have asymptomatic disease if they don't have any symptoms at all. So if they have no symptoms, they've never had a fracture, they're not aware of osteoporosis, they've never had kidney stones, and they have hypercalcemia, which is mild, they have asymptomatic disease. Now, if we do investigation and we do a bone density test and we find osteoporosis, we will say they have asymptomatic disease with target organ involvement. And if they don't have any target organ involvement, then we will say that they have asymptomatic disease without target organ involvement. Normal calcemic hyperparathyroidism, it can be diagnosed if someone has consistently normal calcium corrected for albumin, consistently normal ionized calcium, but an elevated PTH on at least 2 occasions over 3 to 6 months. And we have to exclude a physiologic rise in PTH. Now, there may be a physiologic rise in PTH because of vitamin D inadequacy, or because of kidney disease, or because of drugs like thiazides and lithium, or anti-resorptive agents such as bisphosphonates or denosumab. Hypercalciuria causes loss of calcium, and this can result in a physiologic rise in PTH. Malabsorption, if we're not taking in enough calcium or vitamin D or absorbing it, then this will result in a physiologic rise in PTH. And we want to make sure that our patient does not have a physiologic rise in PTH before we make a diagnosis of normal calcemic hyperparathyroidism. And there are other metabolic bone diseases that can be associated with elevated PTH, such as Paget's disease. Now, who should have a DNA analysis completed? for the MEN genes and also for the possibility of FHH? Well, we would consider this in younger people who are under 30, those who have multiglandular disease, those who have a family history of hypercalcemia, and those who have syndromic features of disease in addition to primary hyperparathyroidism. So in younger people, we would think about MEN1, MEN2, MEN4. Does our patient have features that would make us concerned about the possibility of multiple endocrine neoplasia? Do they have hyperparathyroid jaw tumor syndrome? These parathyroid adenomas are associated with benign ossifying mandible fibromas, and cancer is more commonly seen in these patients. Or do they have one of the three variants of FHH, where we can have FHH1, FHH2, FHH3. So when we evaluate our patient, we have to ask ourselves, is it isolated, non-syndromic, or does our patient have syndromic features? If they have other features of other diseases, then we would definitely do the DNA analysis for the MEN1 gene, the RET oncogene, the CDKN1B gene, and the CDC73 gene. And if they have isolated disease, then we would be thinking about FHH, because FHH is isolated. So it could be calcium sensing receptor, GNA11, AP2S1 gene. And you can also have isolated primary hyperparathyroidism in MEN1. And early MEN1 can present with primary hyperparathyroidism. So familial isolated hyperparathyroidism, usually there's a mutation in the calcium sensing receptor gene, or it could be MEN1 or the CDC73 gene. These individuals, even though they may have multisystem manifestations of the underlying mutation, it can present as isolated. So our recommendations are surgery is recommended in the presence of severe hypercalcemia, in the presence of skeletal involvement or kidney disease in young people as well. But even if they don't meet these recommendations, we said that a patient can go on to have parathyroidectomy if there are no contraindications. And if we choose not to proceed with parathyroid surgery, what are the treatment options that we can offer our patients? And we did a systematic review of all of the medical options, and we have evidence that bisphosphonates can provide skeletal protection. So can estrogen and raloxifene. Cinacalcet is like a chemical parathyroidectomy. So cinacalcet will bind to the calcium sensing receptor, and it is an allosteric modulator of the calcium sensing receptor, and it increases the sensitivity. It's a calcium mimetic agent. It increases the sensitivity of the receptor, and it turns off PTH. And so it will be like a chemical parathyroidectomy. And we can also give denosumab for skeletal protection. And we can combine cinacalcet with denosumab. We do have a small study showing us that combining cinacalcet with denosumab results in improvements in bone density and declines in calcium. Here's our multi-center data looking at alendronate in comparison to placebo. In patients with primary hyperparathyroidism, we saw improvements in the spine and in the total hip bone density. We did not see any change in calcium or in PTH. Here is our phase 3 double-blind randomized controlled trial looking at cinacalcet, 30 milligrams BID, going all the way up to 90 milligrams TID, and we demonstrated reductions in serum calcium and PTH with cinacalcet. And when the placebo group switched to cinacalcet, we were able to normalize calcium and PTH was reduced. So these treatment options are valuable for our patient. A few points about pregnancy. In a pregnant patient, the breast and the placenta produce PTHRP, and PTHRP will result in suppression of PTH. So in a pregnant woman, the PTH levels may not be as high as we would have expected. But this PTHRP also contributes to bone resorption and activates vitamin D, and our patients can have an absorptive hypercalciuria. In a pregnant woman, we could do a CT of the neck. It is believed to be safe with very low dose fetal radiation exposure, and a neck ultrasound can also be done. And a kidney ultrasound can be done, but obviously those are the only options that would offer for imaging as a preoperative tool. So in pregnancy, we would rehydrate our patient, stop the calcium supplements, and I'll stop hydrochlorothiazide and lithium if possible, correct the vitamin D. We could give our patient calcitonin, or we could potentially give them cinacalcet. The other drugs are not recommended in pregnancy. And we would recommend surgery. Surgery is recommended in pregnancy in the second trimester, ideally in the second trimester. So what did we do for our patient? We went ahead and rehydrated her, and we did a neck CT, and she had a large right paratracheal mass, and she went ahead and we actually did give her cinacalcet because she was severely hypercalcemic. She had an urgent parathyroidectomy. Unfortunately, the final pathology was a parathyroid adenoma. So to conclude, parathyroidectomy is always an attractive option for patients with asymptomatic disease. If our patients do not meet the revised guidelines for parathyroid surgery, they could be potentially followed safely. Nitrogen-containing bisphosphonates and denosumab provide skeletal protection, and cinacalcet lowers PTH and calcium into the normal reference range. And during pregnancy, we recommend parathyroidectomy in the second trimester in the presence of severe hypercalcemia. But in our patient, we had to do it in the third trimester because she was severely hypercalcemic. So with that, I would like to thank you for your attention, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Aliya Khan, for this excellent presentation and review for the topic. Since this is a plenary session, we don't have any Q&As. I would like to end today's sessions, and also for the 2 days sessions that we had within the Congress. Thank you so much for attending all these sessions. I give the mic now to our president, Dr. Nasser Al-Jahani.